Tissue Integrity Part 6, Introduction to Nursing Concepts, Martha Olson. As we look at our pressure ulcers, we have to think of the contributing factors for getting a pressure ulcer. Pressure intensity, duration, and tissue tolerance are talked about on page 1177 in Potter and Perry. I highly recommend that you look at that area. Our contributing factors, as we look at what they are, we need to also think about what we as a nurse can do to prevent that. Our two most common sites are the sacrum or coccyx area and the heels. As we look at turning, lifting, or floating the heels, many different things that can be done for that. Pressure ulcers have different names. They can be called bed sores or decubitus. The external pressure compresses blood vessels, so the heavier a person is, the more weight pushing down on that tissue, the higher the risk for that. Also, how a person is sitting. If you're laying in bed, you have multiple pressure points on the body, whereas if you're sitting in a chair, there's a lot of weight and pressure on that coccyx area of the body. Our friction and shearing, those forces tear and injure the tissue underneath. A friction is when two surfaces rub against each other, and shearing is when one layer of tissue slides over another layer, like when you're lifting somebody up in bed and you just kind of drag them up and that skin is pulling against the sheets the whole way. Looking at our assessment, we should get in the habit of looking for those areas of high risk skin breakdown on admission, and then based on a periodic evaluation for the risk that they are. It is not just old people or our aging adult that have issues with the skin. I have seen very young pediatric patients that have been on traction or bed rest for a variety of reasons that have issues with their skin. What patients would you need to assess more often? That really is that critical thinking that makes you the RN, knowing that they have high risk factors and need to be looked at more often. Anybody with a history of skin breakdown, with moisture to the skin, high Braden scores on admission or periodically, and then the person with decreased sensation. So your patient that's ventilated on a ventilator in the unit, maybe your patient that's unresponsive, your end-of-life patient that does not have a lot of cognition is having high risk for that. On page 1188, it lists all of these. As we look at this list, start formulating a type of question I would ask that would be, which patient is at highest risk for having a pressure ulcer? Knowing the risk factors, then be able to translate that into an application type question where we look at who might be at the very highest risk. Besides obesity, the other thing I would add to this slide that's very busy is the very thin. Both extremes of the weight gain, because the obesity, as I said, has a lot of weight on that tissue pressing down to close that capillary pressure, not allowing blood flow to go through. But the very thin person doesn't have any sub-Q tissue to kind of pad or protect those bony prominences that we have. So our prevention on 1195 in Potter and Perry really begins with early identification, repositioning, looking at incontinency issues or moisture issues, and then what type of bed or mattress do we have for them. I put this picture in there because I think of this person sitting there enjoying the day, but it makes me also wonder if this older patient tucked in the corner of their room is not on the call light, which it doesn't appear that they have one with them. How long would the nurses' aides and the nursing staff allow that person to sit in the wheelchair without attending to them if they're quiet and not causing a lot of problems? In the wheelchair, it says that they need to shift their weight or reposition every 15 minutes because of the extreme weight to that lower coccyx area that is high risk for breakdown. 1177, 1178 talks about these three main factors. Your pressure intensity is weight and what extremity it is. Our duration is the amount of time and the amount of pressure. And that's why when we have somebody at high risk, we don't even wait 2 hours to reposition. We're doing that more often than that. And our tissue tolerance is how healthy is that tissue versus their very thin, fragile tissue. Maybe it's somebody with malnutrition or nutritional issues that cause them to have poor skin for high risk. Looking at our pressure points, then we know areas, this is on page 1189 in your book, those areas that are high risk for us behind the ear, sometimes the back of the head. We've all seen babies that are left in the car seat too long and they rub their little hair on the back of the head off. And that also happens in our patient that's hospitalized. And so looking at this, think of all the places you would want to put a pillow or support that weight of the body to remove that pressure point, intensity, and time. Our pressure ulcer then can become more problematic the deeper it gets. It's staged 1 to 4, and we look at 1 being that tissue or that skin that's a little bit boggy. When you feel or palpate it, it feels squishy or spongy underneath. In looking at this stage 1 on page 1180 and 1182, for a person that's Caucasian, it's easier to see. The only way on some of your dark-skinned people is to be able to palpate and feel that that tissue feels different to your sense of palpation. It's non-blanchable erythema of intact skin. The lesion is going to very soon break open if we don't take some very corrective actions at this point. Our stage 2, then, we have the open skin. So here is where we jump very high to that risk for infection because you don't have that barrier, that outer barrier now protecting. It looks as a blister, maybe a very shallow crater or an abrasion. And as we look at this person, it appears in the picture as if it's on the coccyx area. This stage 2 is open. Now to a stage 3, you can see the development then to the tissues underneath, the larger area. It's more of a full thickness where we have the ulcer into a deeper crater, and maybe it's tunneling or going to the tissue surrounding it. Our stage 4 is very extensive destruction. Probably the worst one that I've seen was a Vietnam vet that sat too long, and he was paralyzed, sat too long in his wheelchair, and because he's paralyzed, he could not feel that it hurt or he needed to reposition, and had extensive tunneling and damage to that coccyx area when we would do the dressing change. It was very large and necrotic smelling, and so when we had our mask on to go in and do the dressing change, we would put Vicks Vapor Rub under our nose so that we wouldn't smell that rotting necrotic tissue under there. Our treatment then is to cleanse it. Remember, our normal saline is going to be probably the best option because it does not irritate. We want to irrigate with pressure. Remember the 19 gauge 35 milliliter syringe so that when we irrigate it's under the right amount of pressure, or PSI. We debride, and that's where we put the dressing in moist, and then we take it out dry so that it pulls that necrotic tissue off. And then maintain the ulcer bed moisture so that those epithelial cells want to come to the surface and help heal it in a quicker fashion. The skin around it needs to be maintained as clean and dry, and then use your nursing judgment to determine and chart, is it getting better, is it getting worse, what else do we need to do with that. Years ago, we would treat with heat lamps thinking heat would cause the cells to heal quicker or cause vasodilation to that area, but what we found is any stage of decubitus ulcer had more skin damage because of the heat to that. Donuts are kind of a donut-shaped pillow that you sit on, and they used to put those down in the chair before somebody with a ulcer to their coccyx area sat, and what they found is that actually it did more damage to the surrounding tissue. And then the old wives' tale of putting sugar inside of the wound to promote tissue healing also found that it actually just promoted bacterial growth and caused more problems. So we have certain things that we know through evidence-based practice that does not work, and certain things we know that we need to be doing. So our goals overall are to, number one, prevent pressure ulcers by looking at our Braden scale, identifying those high-risk people, and then putting the measures in place to prevent the skin breakdown. Identify it early, and then when we do have patients that come to us with these complications, we need to treat them in a manner that promotes healing in an environment that we know is good. Our complications can be ulcers, our osteomyelitis, or all the way down into the bone getting an infection. Sepsis then would be that ulcer that causes an infection throughout the body, and then the tracts or the tunneling in that can go quite a ways down into certain parts of the body that are hard to heal because if you can't see them or feel them, they have to again be packed with your sterile dressing and allowed to heal by secondary intention, and that sometimes can take a long time. Besides pressure ulcer care, the other ones that I think of with the tracts and the sepsis are the people that have pilonidal cysts that have to be packed. And as students on the weekend, we would pack a lot of them because these are people that come in to same-day care through the week, and then on the weekends come to the medical floor to have their wounds packed every day for us. As we look then at our pressure ulcers, the contributing factors of shear, friction, moisture, nutrition, infection, and age, some of those, there's things as nurses we can do to help prevent the pressure ulcer from developing or to get it healed in an appropriate manner. This ends number 6. Thank you.